An Introduction to Large Vessel Occlusions, LVOs. You're working in the ED and EMS brings in a new patient. The patient was seen slowly veering off to the side of the road and hit a guardrail. After the accident, EMS noted that the patient had trouble putting words together and was looking towards the left instead of straight at them, concerning for a major stroke presenting with cortical signs. You know that time is of the essence to evaluate this patient and identify their symptoms. Approximately 24 to 46% of acute ischemic strokes are caused by large vessel occlusions, or LVOs, which result from the obstruction of large proximal intracranial arteries. These include the internal carotid arteries, proximal middle cerebral artery, anterior cerebral artery, posterior cerebral artery, and basilar artery. LVOs most commonly affect the internal carotid and middle cerebral arteries, causing stroke symptoms that localize to the cortex, also known as cortical signs. It's important to recognize these symptoms to identify a possible LVO and make rapid decisions about treatment options for the best chances of a good functional outcome.
The four major cortical signs to recognize are aphasia, gaze deviation, neglect, and visual field deficits. Acute onset of these signs is highly suggestive of an LVO stroke. Aphasia, which commonly localizes to the left MCA territory, is a disorder of language. Two major types of aphasia include Broca's aphasia, in which the patient comprehends but has trouble expressing coherent speech, and Wernicke's aphasia, in which the patient can produce words but speaks nonsensically and lacks comprehension. Gaze deviation can occur due to lesions to the frontal eye fields. Both eyes will deviate towards the side of the stroke in LVOs affecting the MCA. For example, deviation of the eyes towards the left suggests a stroke in the left MCA territory. Inattention is a lack of attention or awareness of one side of somebody's world, whether that be visual, tactile, or conscious awareness. Neglect commonly localizes to the right parietal lobe or right MCA territory, causing a patient to lose awareness of their left side. For example, if touching both arms of a patient, they would only sense touch in their right arm. Visual field deficits present as perceived loss of vision, where the same half of each eye's visual field is missing. This is referred to as homonymous hemianopsia. The lesion can localize to any unilateral area along the visual pathway between the thalamus and visual cortex, including the optic radiation.
In any emergency presentation, first perform an airway breathing circulation or ABC assessment. Then, if you identify cortical signs, as in our patient, obtain rapid head imaging. CT head without contrast should be prioritized to rule out intracranial bleeding. Once this is ruled out, vessel imaging of the head and neck, preferably with CT angiogram, is the next step in diagnosis. Once diagnosed, faster treatment results in better outcomes. Patients with LVO may be eligible for acute interventions, such as IV thrombolytic therapy, which is administered within 4.5 hours of when the patient was last known to be well, and mechanical thrombectomy, which is performed within 24 hours of the last known well time. Eligibility for these treatments depends on certain criteria for each, such as time of onset, stroke severity, and presence of salvageable tissue. The case represents an example of left MCA LVO. The patient presented with cortical signs of gaze deviation and aphasia. They should be evaluated as quickly as possible in the emergency room to obtain neuroimaging and be considered for acute treatment options. Early detection and treatment of an LVO could lead to better functional outcomes, reducing disability and mortality.
For more information about this and other neurologic conditions, please visit aan.com/neurobites.